So what I intend to do today is to discuss this topic, sarcopenia and stroke. I will spend the first part of the presentation on the topic of sarcopenia, and then try to connect it to the main topic of your conference. In terms of disclosures, I have funding from NIH, and these are the grants. I do not have any other potential conflict. I think the main reason why we're here today is, and why we talked about sarcopenia, is because of a demographic change that has been noted over the last 2 centuries. This report that was just published by the United Nations, the World Social Report 2023, updated the basic statistics on the population of the world. And as you can see, the prediction is that by the year 2050, 1.6 billion people around the world will be in this age group of 65 or older. And in fact, the fastest growing group is the 80+ age group. So very clearly, you can see that the population that is at a higher risk of stroke, it will continue to increase. Now, this is happening all over the world. This is not limited to one country or one continent. You can see all regions of the world here and here show the same trend. And in fact, most of the people in this age group in the future will be living in the low and middle income countries. So this is not something that is completely dependent on the economic growth of a country, although there is certainly a relationship there. The other point that I want to make is that it is not only that life expectancy is increasing in both men and women, and actually women's life expectancy is much better than men's. But the issue that there's a difference between life expectancy and health adjusted expectancy. And as you can see, in this case for the women, this arrow shows that these many years, the person will be alive, but not necessarily healthy. And that's where the rehabilitation discussion comes into play. Now, it is very hard to define aging. There is no universally accepted definition of aging, but I think you can look at these 2 pictures, and the difference between the picture on the left and the picture on the right, that difference is what we call aging. There's a lot of definitions in the literature, but this visual, I guess, aid can help us understand the process that we're talking about. One of the issues that we've been discussing over the last 25 years about aging is what is now being called sarcopenia. The term was coined by this gentleman here, Irving Rosenberg, who was the director of the lab. This is where I did some of my initial work. And the main observation was, of course, that muscle mass is reduced as we grow older. Now, these are MRI images of 2 individuals. These are not patients. These are not individuals in a hospital. These are healthy individuals in the community. And as you can see very clearly, the amount of muscle is much lower in the older individual. There's a couple of additional changes that you may note here. One of them is the increase in subcutaneous fat, and the other one is the increase in intermuscular fat. And this change has become of significant interest in the literature. Now, the point is that the term sarcopenia was coined for the first time in 1988, published in 1989. At the time, it was limited to age-related changes, but that concept, that definition has evolved over time. And so right now, we have 2 definitions. There may be 1 or 2 more, but these are the 2 that were most recently published by two groups that have dedicated a lot of time to look at this problem. The one on the left is the definition published by the European group. The one on the right by the Asian working group for sarcopenia. Now, it is interesting that the definition on the left does not include the word age or aging. They decided to define sarcopenia as a disorder associated with an increased likelihood of adverse outcomes such as falls and fractures, physical disability, and mortality. But they do not refer to the age-related concern or consequences. Now, the Asian group took a more classical route, I would say, and define sarcopenia as age-related, loss of mass, muscle mass, strength, and performance. And so you may know that since 2016, the ICD-10 classification has an ICD code for sarcopenia. It is interesting to note that the ICD-11 at this point in time does not have this classification. Is a completely different approach to this issue. But back to the issue of definitions, you can anticipate that if we do not agree on the definition, then the studies that look at prevalence, incidence, and so on may be confusing because they are not using the same base definition. We know that there's a couple of groups, international groups, that are trying to come together and put together a consensus definition that we can all use in our research, but that has not happened yet. Now, the three elements of sarcopenia. Number one is the loss of muscle mass. Reduction in number of muscle fibers, especially the type 2 fibers. Reduction in muscle fiber size of both type 1 and type 2 fibers. There's a lost sensitivity to anabolic stimuli. So protein synthesis is impaired. There's a catabolic state. Some of this really has to do with this particular factor that is now considered to be a very, very important issue, inflammation. And then, of course, the fatty infiltration illustrated here with the yellow color. Now, I want to make it clear that this is not limited to one muscle group. We have studied the extensors of the knee because it is a group that is easily accessible, but sarcopenia is happening in essentially all muscle groups of the body, including the spine, the upper limbs, and the lower limbs. The second element is the loss of skeletal muscle strength. And there's two issues here. One, of course, you have a reduction in the number of muscle fibers, so you have fewer actin myosin cross bridges. So this is the quantity issue. But there's also a quality problem. The cross bridges that survive do not work well. So there's a muscle quantity, but also muscle quality problem here that is probably associated with myosin protein abnormalities. And number three, all of that expresses itself combined as a loss of physical performance, things like reduced shortening velocity, alterations in walking ability, gait speed becomes slower. And this is very relevant to the stroke population. So why are we interested in sarcopenia? There's a lot of negative or adverse outcomes associated with sarcopenia. So the concern is that if we don't address this particular group of individuals will be at risk of a large number of complications and negative outcomes, falls and fractures, impaired ADLs, cognitive impairments, loss of independence and quality of life, increased mortality, poor prognosis in cancer, for example, and you see the same thing in stroke. So the point is that this condition, the presence of this condition, increases the risk of a lot of negative outcomes. Now, let me make it clear that sarcopenia is not a universal phenomenon. So even though we lose muscle mass and strength as we grow older, not everybody qualifies for the definition of sarcopenia. Another important element is that this is the European group that is now thinking primary sarcopenia should be age-related. There is no other cause. But now we're talking about secondary sarcopenia, and in this case, it's not necessarily age-related. This is where sarcopenia associated with cancer, COVID-19, other chronic conditions, and stroke comes into play. Obviously, chronic sarcopenia more than 6 months is prevalent in stroke patients as well. So how do you make the diagnosis? At the top of the screen, you'll see the case finding approach. So people that have chronic conditions, that have repeated falls, unexplained weight loss, malnutrition, and so on, should be screened for sarcopenia. There's actually a questionnaire that's called a SARC questionnaire. It's a 5-question questionnaire that can help you identify those that have mobility issues and that may be at risk for sarcopenia. Then you measure muscle strength using the hand grip strength test, physical performance, usually with the 6-meter walk test, and the appendicular skeletal muscle mass using the DEXA, which is at this point in time the accepted technique to use. And then you combine all of these results, the results of the 3 measurements based on your normative values, and decide whether the patient has sarcopenia. And you can have the diagnosis if the patient has low mass and low strength or low physical performance. You have to have low skeletal muscle mass. Now, if the patient has all of them, all 3 impaired measurements or lower measurements, I should say, then you can call it severe sarcopenia. So this is the way that sarcopenia is being diagnosed nowadays. In a regular clinic, of course, you can do the first 2 measurements rather quickly and in a very inexpensive way. The DEXA, of course, requires a more specialized center that has the equipment. How prevalent is sarcopenia? You can see here different studies in different countries. I suspect that part of the variability that you see on the slide really it depends on the definition they use to make the diagnosis. So that this is when the issue of not having a single definition limits the interpretation of the studies. In the US, it's probably around 6% for men, 12% for women. In Japan, around 8% for both, and so on. Now, in a very recent study published in South Korea, they did something very interesting because it was not a cross-sectional study. This was a longitudinal study. So they followed this group of individuals over 2 years and determined that the incidence was about 13.5% in men and 11.7% in women. These are people in the community. This is not people in the hospital, but in the community. And they did something that is also very important. They actually determined risk factors, factors that may increase the risk of developing sarcopenia. For example, older individuals, lower BMI, more chronic conditions, lower levels of physical activity in women, lower engagement in resistance training in men, and higher levels of glycosylated hemoglobin in men. So this is probably the first study that decided to take a longitudinal perspective to this issue. So I think these numbers, and of course done with the one of the most recent definitions, the definitions published by the Asian Working Group. So these numbers may actually be closer to real life. Now, this really depends on the population. Again, these were community-dwelling older adults. But in another study published a couple of years ago, they look at geriatric and acute and rehab wards for older people. And as you can see, independent of the definition, probable, confirmed, severe, the incidence or prevalence in that case was much higher than in the community. So I think if you do this in your rehab unit, you're going to find that more people have sarcopenia than if you go to the communities in Baltimore or any other city around the world. So when you look at incidence and prevalence, keep in mind where the data are coming from. Finally, in terms of sarcopenia, the model that we use nowadays to understand sarcopenia is multifactorial, as expected. And you can see that many of these factors may be present in your patients and contribute to sarcopenia. Age-related sarcopenia is now clearly associated with microvascular impairments, inflammation, and this is a very important issue, reduced physical activity, periodic disuse, bed rest, and so on, poor diet quality, changes in hormonal concentrations, GI disturbances, and anabolic signaling impairment. So all of these together contribute to the phenotype that we call sarcopenia. And I don't have to tell you that many of these are present in your stroke patients. So why do we make the connection between sarcopenia and stroke? Remember, according to the European Working Group on Sarcopenia, stroke would be one of those causes of secondary sarcopenia, independent of age, although these two factors may or conditions may interact with each other. But here is a good justification for the discussion. This was published very recently in 2023 by the Japanese group, Domin and collaborators. And they were looking at independent predictors of functional outcome. And not surprisingly, the skeletal muscle mass index, and this is usually measured with the DEXA, was one of the most important predictors of functional outcomes. And as Dr. Ragaman was discussing in the introduction of the center, function is really what or functioning is what the patients are after. So we need to keep in mind that that's really, for most people, the most important outcome. Now, if you look at changes in skeletal muscle after stroke, many of them are very similar to what happens with age or aging. We have disuse atrophy, of course, inflammation, denervation. We have problems with nutrition. We have oxidation of tissues, fibrosis, and so on. All of these leading to a number of changes that are very, very similar to what happens with age-related sarcopenia. At the end of the day, stroke patients also see reduction in muscle mass and muscle contractile function. There's a couple of differences, though, with when compared to the aging. It looks like it may be an increase in type 2 fast-twitch fibers, which is not the case with aging. The typical change in muscle fiber type composition with age is a reduction in the number of type 2, especially 2A fibers, and an increase in the prevalence of type 1 fibers. So there are some differences here between the two conditions, although the bottom line is essentially the same. So loss of muscle mass, about 25% loss, accompanied by increased deposition of fat and connective tissue. This is clearly an outcome that is very similar to what happens in age-related sarcopenia. Now, this is a muscle fiber shift that I was referring to. With aging, we actually see more type 1, less 2A and 2X. In the case of stroke, it is the opposite, essentially. It's not clear exactly why this happens, but it is an important difference that we may have to take into account in rehabilitation programs. So this combination of stroke and sarcopenia as a research topic is becoming more popular, I would say. You look at PubMed, you look for papers published with a combination of stroke and sarcopenia. In 2022, there were about 100 papers published in this particular topic. But you can see that in the early 2000, there was nothing being published in this area. If you take all papers together, the prevalence is between 14 and 54%. The wide range tells you a little bit about the problem of using existing definitions to make the diagnosis after stroke. Clearly, these patients may have malnutrition problems and so on that contribute to sarcopenia, and these are elements that we need to take into account. Of course, aging can be associated with these two conditions as well in the absence of an injury to the nervous system. Decreased mobility and activity and spasticity. Now, this is a very important issue, and I'll talk about it in more detail in the next few minutes, but the issue here is that we have a problem in the interpretation of the changes in muscle because of the presence of spasticity, which is not the case with age-related sarcopenia. Now, in this particular study, they look at trajectories, that is, pre and after stroke, how frequent the sarcopenia develop or becomes an issue. And these black squares show the prevalence, the average prevalence of sarcopenia before stroke in this particular group of individuals. This is 10 days after stroke, and this is 30 days after stroke. So the point, the message of the paper is the prevalence will increase after stroke for all of the factors that we talked about. And so we need to think about early interventions to actually prevent this from happening. And it was clear from Dr. Ragaman's presentation that this is indeed the case in your model at Johns Hopkins. But to see this number here, it's close to 50% prevalence after stroke, which is a huge number. Now, what factors may predispose individuals to develop post-stroke sarcopenia? And some variables have been identified, just like in the case of aging. Obviously, older individuals and history of chronic diseases may predispose the development of sarcopenia. Other variables that may reduce development of sarcopenia, these are the good ones, of course, quitting smoking, having good nutritional status, and in this case, it's not only overall nutrition, it's actually the protein, specifically the protein content of the diet that has been shown to have an effect on sarcopenia, and not only total protein, but specifically leucine as an amino acid. Early rehab may actually have an impact. The stroke severity, of course, that makes a lot of sense. And things that may be protective against sarcopenia are rehab-related interventions that you're familiar with. So it is interesting to see that walking speed and gait speed is actually a very important issue here. And those that have more problems walking may be at risk of higher incidence or prevalence of sarcopenia. Like it shows here, stroke survivors who are not able to walk unassisted have a higher prevalence. And this is not only because they cannot exercise the muscles. There's something else happening with this group of individuals. And the presence of sarcopenia interferes with rehabilitation. So this is a justification to intervene early. And if we identify sarcopenia early in the process, that predicts poor recovery. That is the point that these researchers were trying to make. So we need to look for sarcopenia early in the process, intervene to avoid its development, and hopefully that will enhance the chances of recovery. I'd like to share a few of our own research. These are papers that we published in the last couple of years on this particular topic, and I'll just share with you some of the perhaps more important findings. This was a cross-sectional study of chronic, this is important, chronic stroke patients. We did not look at acute stroke patients. They all had hemiplegia, at least 6 months from stroke. And we excluded some individuals that we felt that they didn't qualify because they were doing other things that would interfere with some of the measurements. We measure spasticity using MAS, Vogel-Meyer, grip strength, walking speed, and DEXA. These are the 3 criteria, as you may remember from earlier slides to diagnose sarcopenia. And in addition to the DEXA, we did ultrasound images of the muscles of the upper and lower limbs. This research was done in collaboration with our colleagues at TIER in Houston, Texas. And essentially, this is what we found. The prevalence of sarcopenia between 18 to 25%. Now, immediately saw a problem. That is, one of the diagnostic criteria is the hand grip strength. If you use the affected side, everybody may have a lower hand grip strength, all of the patients. So using that particular criteria, almost everybody had sarcopenia. If you use the unaffected side or less affected side, then the prevalence was 25%. So here we have an issue with the current definition and the application of the measurement techniques. Slow gait speed, 86%. We allowed them to use the orthotic devices so they could walk at the regular speed. And the prevalence of low muscle mass was close to 90%. We use DEXA, as you can see, and for the DEXA, we limited ourselves to the use of the appendicular skeletal muscle mass, which is the way to do it. And these are changes in body composition. In black, the affected side, in gray, the unaffected side. And as you can see, there was a reduction in muscle mass, bone mineral density, and increasing percent fat in the affected side compared to the unaffected side. And that was true for both the upper limb and the lower limb. Remember, they were chronic stroke survivors. Now, when we compare the upper versus the lower limb, there was a higher loss of bone muscle mass or mineral density, excuse me, and upper limb muscle mass. So evidently there is a difference in the way sarcopenia may impact upper limb muscles versus lower limb muscles. This is important when you plan the rehab interventions to consider exactly where to address a reduction in muscle mass. Ultrasound images, this is an example of the ultrasound images. This is for the biceps. This is the measurement of the size. This is unaffected side. This is the affected side, and then you can see smaller muscle mass. But there's another interesting finding, and that is the echogenicity of the tissue. You can see that this is a bit darker than this area here. And this is a measurement of muscle density, which is an indirect measurement or a proxy for muscle quality. This may be more clear in the lower limbs. You see that there's a lot of black in this image here, not that much in this one. This is the medial gastrocnemius. Again, reduction in muscle size, but not only that, it's an increase in echogenicity, which is again indicating that there's fatty and connective tissue infiltration, which at the end of the day may be more difficult to overcome than the change in muscle mass itself. So we documented changes in muscle not only with the DEXA, but also with the ultrasound. And this is a comparison of 4 muscles that we measure: the biceps, the flexor carpi ulnaris, the rectus femoris, and the medial gastrocnemius. And as you can see, this is the reduction in thickness as a percentage. All muscles show a significant reduction, but the upper limbs show more loss of muscle mass. And here are the changes in the HECMAT scale, which is the echogenicity that I was referring to. So evidently, in these group of individuals, this phenomenon of sarcopenia affected muscles in the upper or lower limbs, muscles that have different functions and mechanical properties as well, and not only in terms of quantity, but also in quality. Now, a couple of additional observations which makes stroke-related sarcopenia a little bit of a different entity. There was no correlation with BT injections. So we don't really believe that the injections had anything to do with what is happening in terms of developing sarcopenia. This is important in terms of the interpretation of the findings. And number 2, these changes in muscle were not related to age or times in stroke or the presence of spasticity. So you take this, all of these observations and you say, well, the phenomenon may be defined as similar to what happens with age-related sarcopenia, but there's something here that is different. It's an expression that is, at the end of the day, the same expression of a process that may be different, and that those differences remain to be defined and identified. So what we know so far is higher prevalence of sarcopenia in stroke, higher than age-related. The use of the different definitions is a problem at this point in time that we need to address. It is clearly multifactorial, not age-related in this particular group. It affects limbs, both upper and lower, but the changes are more significant in the upper limbs. It looks like spasticity may protect from muscle loss. I don't think that we can make this as a final statement. And walking may have a protective role because we see that bone mineral density in the lower limbs was preserved to a greater degree than in the upper limbs. Challenges, we need to address this issue of definition. The use of grip strength of the affected side may not be valid. If you use gait speed, you have to allow the patients to walk with their assistive devices if they use any. The severity of stroke may result in significant variability in the prevalence of stroke. That's something to be examined in the future. And these 2 things down here, we need to continue to study them. In theory, these should actually change the course of sarcopenia, but we need to understand that much better. I really don't have a lot of time to go into interventions, but I can tell you that in the case of age-related sarcopenia, these are the 2 main elements. Nutritional support, and again, as I mentioned before, it is nutritional support with high protein intake, specifically having an increased content of leucine. Whether the protein is animal or plant it really doesn't matter. There's a very recent study show that both can be effective as long as they contain the same amount of leucine and that the plant blend protein diet is significant enough. Both can be effective. And in terms of rehab, the most successful intervention, safe and successful in older individuals, has been the use of strengthening or resistance exercise. In some patients, older studies of older individuals, we've used strength training combined with some sort of balance training like Tai Chi and so on. And those have been shown to be quite effective. So I'll stop there. And again, thank you very much for the invitation to be here today. My intention was to share with you some of the, what I think is the state of the knowledge in sarcopenia, age-related sarcopenia, and then extend that discussion to the stroke survivors, an area that is being researched in a very significant way, but that requires more study, so we can kind of implement early interventions to avoid the development of sarcopenia. Again, thank you very much for your kind invitation and attention, and I'll be happy to take questions if we have time now.